So that's coming through okay there, showing up good. Okay, sounds good. So as Danielle, Paige, and Amon mentioned, my name's Jim. I'm a third-year resident here in ophthalmology at U Ottawa. And the goal for this talk is essentially to talk about some cases. I deliberately chose all cases from PGY2, which is when you start taking call in ophthalmology. And I chose some cases that are not only interesting, but also highlight some very, very important call survival tips and things that you don't want to miss when you start holding the pager in ophthalmology. So it's very much, you know, a practical call survival approach, and hopefully a little bit fun if you like my sense of humor. So the three cases are case one, the Leafs game; case two, "'twas the night before my vacation; and case three, eyes are connected to the body. Okay, so let's get into it. So the first case is the Leafs game. So it's no secret to anyone who's close to me and knows me well that I'm a huge Leafs fan. So I was on call, and it's home call, and I was comfortably minding my own business Saturday night watching Hockey Night in Canada, when all of a sudden my pager went off. And here was the page from the emergency department, pretty much verbatim. So they said, "We're seeing a patient who had an injection 3 days ago for her wet macular degeneration." So that's an intravitreal injection. "She put in one of her eye drops, and then after that, her vision went blurry. She has no pain, it's a little bit red. She wasn't sure if this was because of the drop, but her vision went quite blurry, so she wanted to come in just in case to the emergency department." So what I want you to think about here, and also potentially if we can use the chat, if you get paged like this from the emergency department, what do you want to know? So I'll give it like 10 seconds if anyone wants to put it in the chat. There'll be a few moments like this throughout the talk. If not, we'll just go forwards. Okay, we'll just keep going. Okay, so the first thing, most important thing, I think the Leafs were winning, but I forgot actually, this was over a year ago. But here's some of the things I asked them. So, is there any pain? No. What's the vision? Hand motion. She can normally read with this eye. So a pretty dramatic change in her vision. What's their examination? They thought there was no discharge. There was some conjunctival injection, bit red eye. There's no staining on the cornea. They don't see a hypopyon. They didn't do the IOP because they don't have a tonal pen. So what do you do next here? Oh, sorry, someone actually asked something. What eye drop did she put in? I think it was probably Vigamox, but I'm not sure. Either Vigamox or an artificial tear. Okay, so if you get called by this and they tell you these things, what do you do now? You're at home watching the Leafs game. Think about it. So I just want to highlight this part of the story, okay? So injection 3 days ago, vision went blurry. That alone is a massive red flag, okay? So here's what I did. I reluctantly turned off the TV, got on my scrubs, and went in and saw the patient immediately. Okay, so here's my examination. So hand motion vision, and she can normally read with the eye. Normal IOP. I thought there was some mucopurulent discharge present. A little bit red. Cornea is normal. And there's a lot of cell in the anterior chamber, but there's no hypopyon. And then the very important next part of the examination is the dilated examination, which showed significant vitreous cells, lots of vitreous haze, vitritis with essentially no view of the fundus. So the diagnosis here is post-injection endophthalmitis, okay? So what I did next was I called the retina fellow. If you don't treat this, they lose the eye. So they agreed to do vitreous tap and inject of antibiotics and steroids. So let's talk about endophthalmitis. Endophthalmitis is a rare but devastating intraocular infection. Most often we call this exogenous, where it's from some kind of insult to the integrity of the eye. So be that surgery, intraocular instrumentation, or trauma. It could be also endogenous. It's more rare, but in the setting of a systemic infection, you can get seeding in the eye as well. And this is an emergency and requires prompt treatment to save the eye. This is a picture here that's your classic endophthalmitis picture. I took this from an article in Clinical Ophthalmology. So this patient here looks like they recently had some kind of surgery because there's a suture in the eye. There's a little bit of discharge. There's injected conjunctiva. The cornea might be a little bit edematous, but clear otherwise. And you have a hypopyon here. And, typically you think of wanting to see a hypopyon, which basically represents a significant AC reaction in endophthalmitis. But I want to highlight some things that are, brought about by this case about the variety in which endophthalmitis can present with. So this comes from, the endophthalmitis vitrectomy study. It's an old study now, but you have to memorize it for exams. They talked about different treatments for endophthalmitis, which we will go over because that's what they discussed. But I very much wanted to highlight the data from this study about how endophthalmitis presents, because they have some very, very useful data that's very relevant to our case. So they essentially wanted to see if IV antibiotics make a difference, and also comparing vitreous tap and inject with vitrectomy to see if there's a benefit of vitrectomy in endophthalmitis. So here are some important things about how their patients presented. So for signs and symptoms, red eye 82% of the time, pain about 74% of the time, blurry vision was the most common symptom of endophthalmitis, swollen eyelid, the minority of the time. Patients presented on average 6 days after their intraocular surgery, sometimes before, sometimes after. And then in terms of signs, a significant proportion of patients have only LP vision or worse. A hypopyon was present in 85%, and then 79% had hazy median. So what I wanted to just highlight is 25% of the time, there's no pain based on this study. You can't say that definitively, but in this population, which is really, what guides our management, the landmark study, and 15% of the time, they found that there was no hypopyon. So you can get called for a painless endophthalmitis. You can get called for endophthalmitis without a hypopyon. The important thing is that the patient recently had intraocular instrumentation and has new symptoms. That alone should be enough for you to be highly suspicious. To just go over, their findings in terms of their results, what they found was that IV antibiotics didn't seem to make much of a difference in addition to the ocular treatments. And the vitrectomy was beneficial if the patient had light perception vision or worse, but not if they had hand motion vision or better, as compared to vitreous tap and inject. And it was across their various outcomes. So the conclusion of the study was that, you may omit systemic intravenous antibiotics for a variety of reasons. Vitrectomy is not necessary if they have better than light perception vision, but has a substantial benefit if their vision is light perception or worse. So my take-home messages for this as you become a junior resident on call is honestly, see everyone who's in this endophthalmitis window. So that's basically beyond post-op day 1 to, post-op a week or two. At the very least, you should have a very low threshold to see any patient presenting with a new complaint that's in this window, even if it's not your typical mental model, the classic presentation of endophthalmitis. I've caught, 5 of them, which is kind of a lot, I guess, on call, and it's always different. They can have no pain, they can have no hypopyon. Our patient had neither of these two things. They can present with only blurry vision, and also you will be on call during Hockey Night in Canada when you are on call on the weekend. And also just some other important data from the literature. So if you look here, the Leafs are 3rd in the league. If you look closely and look far enough down, there are some other Canadian teams as well. Okay, so let's keep going. All right, case 2. it was the night before my vacation. So I was finishing up a weekend of call and just before starting a week of vacation, and I got paged by emergency at about 8:30 p.m. Here's what they said. We're seeing a patient here with nasal visual field loss to her right eye and preserved central vision. Her symptoms started at about 7 p.m., so about an hour and a half ago. We're worried about a retinal detachment with the macula on. So bottom line, MAC on RD, this is a picture of one. So basically their macula is flat, but they have a detachment. You have to see them. You should probably try to diagnose them before 10 p.m. for when you call Retina. So what was going through my mind here was, oh man, I got to get in there, because I mean, by the time I get in there and dilate them, the clock's ticking. So, I raced to my 2009 Ford Escape and, drove to the hospital as fast as I could. So the assessment here is basically take their vision and check their pupils as fast as possible and then dilate them so that you can get a look at the retina. Then, get a history, I guess. Okay. So, I did their vision, it was fine. They had no RAPD. So as I was reaching in to the drawer with the drops in it to dilate them, I was asking them, so like, what's going on actually? What's going on with your vision? So she said, well, I couldn't see the left half of the room with both eyes open. It's getting better, but I still think that the left half of my vision is worse than the right. So immediately I stopped and I thought, hold on, hang on a second. That's kind of weird, because if I remember the afferent visual pathway, if you lose the temporal retina and lose the nasal part of your visual field out of your right eye, well, I mean, you can still see over there. Like, you have your entire left eye. So why would you lose the left side of your vision from just a temporal RD of the right eye? So I put down the dilating eye drops and I did a confrontational visual field exam, which showed that she had a left homonymous hemianopsia. I took a quick undilated view of the retina, which was flat. So to summarize the presentation, it's a sudden onset left homonymous hemianopsia, which started between 2 and 2.5 hours ago. The deficit has subjectively improved, but is still present, and she has no other symptoms. So this is one that I'm kind of hoping someone can say in the chat, like, what do you do now? Like, this patient's in front of you. You're by yourself as a resident Sunday night, seeing this patient. What's your next move? I'm hoping someone actually says something. If not, that's okay. Okay, so here's what was going through my mind. This, okay? So, the patient is now presenting with a new sudden onset neurologic symptom, and they're in what's called the TPA window. So essentially, TPA is the drug that you give people if they're in an acute stroke and they don't have any of the exclusion criteria. Usually it's because they presented too long after their symptom onset, but also some other things in terms of, hemorrhage and so on. So this patient is a candidate for TPA, which is an emergency, okay? And I'm by myself. So this was my next move. So I called the staff ophthalmologist, the staff neurologist, and told them the case. And luckily enough, they were actually in-house. So they came to the Eye Institute and examined the patient immediately. They actually had full confrontational visual fields, but there was a subjective decrease on the left. The rest of the exam was normal. So at that point, the differential diagnosis was an acute stroke versus a TIA versus a migraine, given that it seems to be improving. So we called what's called a stroke code, which is basically where you think someone's having a stroke, so you can immediately get them imaging and potentially TPA. So when the stroke code is called at the general hospital, it's responded to by the ICU team because the inpatient neurology team is at our other hospital. So interestingly enough, my junior resident in ophthalmology was on ICU and responded to the stroke code. So she said it was kind of weird when she heard overhead stroke code eye institute. I was like, what's going on? Okay. So we did the stroke protocol. The CT-CTA showed no hemorrhage, no vessel cutoff, no established infarct. The deficit was improving. So the decision was made to not give TPA and discharge the patient on dual antiplatelets and obtain an MRI. Part of the criteria for getting TPA is a lasting residual deficit, which the patient no longer had. So we did the MRI, and they had a small area of restricted diffusion in the right occipital lobe and right parietal lobe, consistent with subacute infarcts. So, you know, it is a small lesion, and you can get DWI hits from a migraine. So the neurologist, I follow up from their chart. The neurologist is treating it as a stroke. So they finished the dual antiplatelets and they remain on Plavix, which is my next slide. But, you know, essentially, the important thing here is, like, you always want to ask about the other eye. Know when to stop, right? So I was like reaching for my dilation drops, and then they said the thing about their vision, and then I stopped, and then I did computational visual fields. You're gonna have to call staff sometimes to advocate for your patients. Okay. Any questions? I have one more case. Okay, I'll see if they come up in the chat. Okay, so this is the last case. Eyes are connected to the body. Okay, so a previously healthy 54-year-old woman presents with bilateral blurry vision over the last few weeks. She recently has had some mild occipital headaches, but feels well otherwise. Oh, actually, I'll answer this. Would you do a screening full neuro exam before calling neurology staff, or just call first? I probably could have. That's actually a good point. They didn't ask for it when I called them, so it seemed like it didn't really change their management. I guess what I would say is that my examination identified a new focal neurological deficit, meaning that the next management step is stroke code, whether or not I identify anything else on my exam. Like as the ophthalmology resident, it would have been helpful to do that, because then I could have, you know, maybe identified other parts that might have been involved if they were having a stroke to help them localize the lesion. But realistically, when you call a stroke code, the patient gets a CTA, and then the stroke team does the NIH-SS exam on them immediately as well. So they get the stroke neurologic screening exam done as part of the NIH-SS. As a resident on another service that's asking for or calling a stroke code, it's probably reasonable to say that you just have to have identified a new focal neurological deficit and the need for a stroke code. Although you probably could have gone above and beyond and done an exam. I guess for me, I just felt it was a bit time sensitive, because if they ended up actually needing TPA, they would have had to have been transferred to the other hospital, and they were already like close to being outside the window, even when I examined them. Yeah, hopefully that answers your question. Okay, so this case, you know, it's basically a generally well-feeling 54-year-old woman with no past medical history. So on examination, she's 20/25 in her right eye, 20/70 +1 in her left eye. Pressure is normal. There's like an early cataract in both eyes. And then her dilated fundus exam. So these are not my photos, but they basically identify the same things that she had. So she had bilateral exudative retinal detachments, multiple cotton wool spots in both eyes, and flame hemorrhages in both eyes. Her OCT, this is her OCT. I think the bottom one is whatever the one was with worst vision. So the bottom one is your left eye. So there's some subretinal fluid. I think this is like the edge of the exudative RD in that eye. So if you see this, what do you do next in clinic? What's the like emergent thing you have to do on exam right away? Anyone know? Okay. Yes. Thank you. Blood pressure. So this was the blood pressure. So it was 230 on 120. Um, and then she also had some other interesting findings on her exam. So some skin thickening and changes to her facial expressiveness as well. Dry lips. So the initial diagnosis in our clinic was malignant hypertension resulting in hypertensive retinopathy and bilateral exudative retinal detachments. So she was immediately transferred to the emergency department for workup and management, and then subsequently transferred to the intensive care unit with medicine and nephrology consults. And as we mentioned earlier, my other resident, my one co-resident, or sorry, junior resident responded to the stroke code. So my other junior resident was on ICU when this patient was admitted and rounded on them during their stay. So I just find it funny that for two of my cases, my juniors were involved in their care on the other side. So she had an acute kidney injury and hemolysis. The antibodies here, so ANA is kind of a non-specific antibody positive. This anti-PM SCL is like for a couple things, but including scleroderma. And then this is one of the phospholipid antibodies. Ultimately, she had a renal biopsy which showed systemic sclerosis, including thrombotic microangiopathy involving the arterioles and glomeruli, severe interstitial fibrosis, and tubular atrophy, leading to a diagnosis of diffuse systemic sclerosis and Sjogren's syndrome, complicated by scleroderma renal crisis that caused her to be in an acute hypertensive episode. And the interesting thing is that her chief complaint was a vision change. On history, when you probe further, she did have a headache, but otherwise she felt fine. She actually didn't even have any chest pain or shortness of breath. So in terms of the ophthalmic follow-up, these are the actual pictures. So this was about a week after her blood pressure was normalized. And it's just a nice, photo showing a couple signs of hypertensive retinopathy. So these little white spots here are cotton wool spots, and then she has some flame hemorrhages as well. I think that she may have still had an RD like up in the superior temporal part of her left eye, but it doesn't really show up here. But this is basically after normalization of her blood pressure. The medical follow-up, so she was ultimately found to have end-stage renal disease and was started on regular dialysis. She's been stable for a while. I kind of keep track of her chart. She's currently awaiting a donor for a renal transplant. Worthwhile just going over some findings in hypertensive retinopathy. So there's a lot of vascular changes that can happen in terms of tortuous and constricted arterioles, arterial venous nicking and crossing, then copper and silver wiring of the arterioles. So some of those are present in this picture here. You can get exudates, you can get cotton wool spots, retinal and optic nerve edema. So it's usually like in terms of like what most often is a severe hypertensive retinopathy, it's usually essential hypertension, like that's poorly controlled. But importantly, in this case, it can be a secondary hypertension and may lead to the ultimate diagnosis of an underlying systemic condition. And if you see things like lots of exudates and heme and optic nerve edema and retinal detachment and so on, these are signs of a more severe hypertensive retinopathy. And then they can have associated other symptoms. Although, like I was saying, our patient actually felt overall pretty well, aside from their headaches. So the take-home points here is that you should always check the blood pressure if there's any sign of systemic hypertension found on exam, especially acute signs. A good example of this is we see tons of patients in our clinic for consult for bilateral optic nerve edema to like rule out intracranial hypertension and so on. But we check the blood pressure on all of those patients because optic nerve edema can be an isolated finding in hypertension. But in this case, there was no florid hypertensive retinopathy. And then the other thing is that you will, it's not that you might, you definitely will uncover severe systemic illness with your ocular examination during residency. So, it's certainly one of the more interesting parts of ophthalmology. And it really just has to do with the fact that you can actually look at someone's blood vessels directly and nerve tissue directly, both of which, undergo changes that can identify systemic issues that are not really well seen anywhere else in the body. So, vasculitis, autoimmune conditions, leukemia, lymphoma, hypertension. I had another patient that I almost put the case in here for who came in with a central retinal vein occlusion in both eyes and was young and was kind of weird. So I sent him down to Emerge and they found that he had polycythemia because his hemoglobin was like, I don't forget what it was. It was like 260 or something or 280. So he got admitted for phlebotomies. So that's still a treatment. So he like got phlebotomy for a while. So it was interesting. So that stuff definitely will happen. We had another patient in the retina clinic who had a retinal lesion found that was suspicious for malignancy. So it was worked up, and then we asked for a CT scan to be done, and she had like a 9 by 7 centimeter, like really big neoplastic lung mass. And then it was successfully treated. She's in remission and feeling well. So there's, lots of stuff like that is going to happen in your residency. I just wanted to acknowledge Gareth, who I think is on the call, who helped with putting together some of the slides for mainly the endophthalmitis and hypertensive retinopathy cases. These are my references. And then also, I just wanted to highlight the fact that you should have fun in medical school. So we have a class band we had a class band in medical school and I was kind of the leader of it. And I have a background in metal music. So, this is me in second year of medical school, playing for my classmates and having a good time and kind of taking it a little too far maybe. So good times. I'm happy to take any questions about the cases or ophthalmology in general. Thank you for your attention.
Well, thank you so much, Jim. I'm going to stop the recording so that anyone can ask questions.